Yes. So I will be talking about the Indian guideline RSSDI. Being an RSSDI president, I would like to complete it in less than 10 minutes or 12 minutes so we can have one or two questions. If I delay, I'm sorry for that. So rationalizing anti-diabetic therapy based on RSSDI guideline. I don't have any conflict of interest or any financial disclosure for this talk. Just to start with that, we know that diabetes is having multiple pathophysiological defects. This we know since long. This is D. Fronjo's slide. I'm sure everybody must have seen it multiple times, so I'm not talking more about it. But we Indians are different, and that is what I just want to tell. Then why we need a different guideline. We are not same what Europeans and Americans are there. We are thin, fat Indian, and that's what I just want to tell, that Indian diabetics are different. We have higher prevalence of diabetes and pre-diabetes. Our diabetes is 1 decade earlier. We have higher diabetes related complication also. We have large rural urban divide. There is a cost of diagnosis, treatment, monitoring and prevention is whatever the cost which we are seeing, that it is less, but in compared to what our patients can afford, it is slightly higher. We have more sedentary lifestyle. We are more physically inactive. We have limited resources. We have poverty, illiteracy, psychosocial, cultural factors are there. And that is what we try to include in our guidelines. So when we are talking of RSSDI guideline or Indian guidelines, we are making guidelines since 2015. This was our latest guideline in 2020. We will be getting out our new guideline in 2022. It will be published. We have come out with a very unique approach, and this approach was appreciated all over the world. You must have seen all the guidelines in the world. They don't have this ABCDEFGH approach. We have come out with a therapeutic circle, while most of the guidelines have in a tabular format. So I mean, we are different, and we made our guidelines also in a different form. We decided that a choice of an anti-diabetic agent should take into account the patient's general health status and associated medical disorder. The patient-centric approach may be referred as an ABCDEFGH approach for the diabetes management. We will show you what is the therapeutic circle. For a patient who has been diagnosed with diabetes, consider a combination of therapy of metformin and one of these treatment options based on A for age, B for BMI, C for CKD, D for duration, E for established CVD, F for financial condition, G for glycemic status, and H for hypoglycemia concern. So when you are deciding the therapy for a patient, you have to see these many factors in the patients. Drug choice should be based on patient preference as well as presence of various comorbidities, and that's what we understood, that established cardiovascular disease and CKD, these are two very important comorbidity which we must understand when we are starting the therapy or when we are escalating the dose of the drug. The goal of reducing blood glucose level while minimizing the side effect, especially hypoglycemia and weight gain. A comparative effectiveness or meta-analysis suggests that overall each new class of non-insulin agents which is added to initial agent, A1C decreases around 0.8 to 1.1. So this is our therapeutic circle where we had put ABCDEFGH approach. When you have going on the red side, it is lesser, wider options are available. When you see the green side, it is the wider options which are available. So this is how in a hierarchy you have to move from inside to outside, and you have to see which is the molecule which is available. Now we have app also which is available with this, and if somebody is a primary care physician, he can know that, you know, this type of patients, how he can decide the therapy. And I will give one or two example of the clinical case where you can decide as per the RSSDA therapeutic guideline what should be the choice of therapy for that. The A is very important. The age of the patient, who is the younger the patient, we would like to have a tighter glycemic control. And the elderly patient, we would not be very, tighter glycemic control. We would not like to opt for a very tight glycemic control as age is advancing for that. BMI is very, very important. Higher the BMI, you would like to add the molecule which will not further increase the weight of the patient, while you should use the molecule which will decrease the weight. And that's the reason the BMI of the person who is sitting in front of you to decide the therapy is also very, very important. And the newer class of the molecules, as Dr. Manoria was talking about, the GLP analog and the SGLT2, both these molecules, they decrease the BMI, and that's very important. See, as I told you, very important comorbidity. Each and every patient who are coming to us, only on A1C we cannot decide the therapy. We must know what is the status of kidney, because there are molecules which will, their dosing will be different as their eGFR is different, and there are some molecules which cannot be used also in the patient who have the CKD or eGFR when it goes less than 30 also. The duration of diabetes is very important. As we know that lesser the duration you can have, more early, and I mean the tighter glycemic control you can afford, while the person who is having duration of diabetes more than 10-15 years, like sulfonylurea, they may lose their efficacy. So I mean the duration of diabetes is also very, very important while deciding the therapy, and particularly it is very important when you are escalating the dose. So some patient who is coming to a clinic who is already having 10 years of diabetes with already 2, 3 or 4 drugs he was already on, now there is no point of further increasing the dose of this patient, while rather than to adding the insulin that will help more. So the duration of diabetes, first time we thought of in the guideline it should be included, while if you see the international guideline they had not put the duration of diabetes is a very important factor to decide the therapy. Established cardiovascular disease is very, very important. I am sure everybody had talked in this forum also. We'll be talking more about the CVD and anti-diabetic agent. So once the person is having either established cardiovascular disease or having multiple risk factor for cardiovascular disease, the choice of therapy differs, and then we have to add the molecule which have benefit like SGLT2 inhibitor or GLP-1 analog, which are CV beneficial drugs, should be added in the drugs in the therapy rather than using the other molecules. The financial condition of the patient, as I told you, in India the patients who can't afford, and there is a limited resources for them, they can't afford all the newer molecules. Now thanks to the companies who could bring out the SGLT2 inhibitor also at a cost effective price, and but still the finance is a major issue or challenge for clinician to decide the therapy. So you may like to add the best therapy for the patient, but the patient's condition can't afford it, so that we should consider while deciding the therapy for type 2 diabetic patient. G is the glycemic status. Now here, what is the A1C? As I told you, the non-insulin therapy, most of them are going to reduce the A1C by 0.8 to 1.1. So the doctor has to make that this much expected A1C reduction will be there after 3 months. So I mean, if he is putting the patient with a 10 A1C and adding only one molecule, or the molecule which is not going to decrease the A1C by more than 1 or 1.2, there is no point, because after 3 months again patient will be uncontrolled. As Dr. Rai was talking that even in US, only less than 1/4 of the patient are actually achieving the comprehensive control in diabetes. I'm sure in India the situation is the same. So I mean, we should know that what is the glycemic status, what is the overall glycemic load of the patient, what is the A1C, what is the fasting, and what is the postprandial. And if we can see the glycemic variability, the dose of the medication or the further escalation of the therapy should decide all those things in the glycemic status also. The hypoglycemia concern is very, very important when you are putting the patients on any drug. We know that insulin, premix insulin are causing more hypoglycemia, and the sulfonylurea, which can lead to hypoglycemia. So what type of patient which you are treating, how much he is prone to develop hypoglycemia, and what could be the consequences if you are dealing with an elderly patient already having a history of hypoglycemia unaware patient having a history of diabetes with 15 or 20 years, having nocturnal hypoglycemia. You should also think of starting the patients on an agent or escalating the agent which can lead to hypoglycemia. You should have that concern also. So the group of patients where one will require avoiding hypoglycemia, particularly the elderly patient or those who have established cardiovascular disease. Now, just to use one case or two case, this is like a 48 years old male businessman with type 2 diabetes of 3 years. He is on metformin. A1C is 8.4. Now, if you take a history of any patient, all these 8 factors will be there. But out of those 8 factors, we have to find 2 and 3 which are very important. And that will decide your second line or the next line of the therapy. Like in this particular patient, he is young, 48 years. His businessman is financially okay. His duration of diabetes is 3 years. He declines injectable and BMI is 32.5. Now, two more important points, his CKD status and heart status. Creatinine is normal and we consider ECG is normal, but he is having multiple cardiovascular risk factors. But BMI is high. A young diabetic patient, affordable, not more duration, 3 years, 8.2 HbA1c, BMI 32.5. Ideal situation is GLP-1 and SGLT2 should be added. Now, this patient is not ready for injectable. Probably a SGLT2 and metformin can be the choice for this patient. So, I mean, this is a simple thing that in patients with all 7, 8 points are there, but you just try to find out which are two important things which you have to decide, which will decide the therapy for this particular patient. In the same way, I'm just putting one more patient. Is a 70-year-old male smoker. Diabetes duration is 12 years. A1C is 8.6. He's already having heart disease. Now, these are some of the conditions which he is having already: stage 2 CKD and heart failure. So now these two are very, very important points for this patient and a 70-year-old guy. So now here avoidance of hypoglycemia is very, very important. Is a elderly male. He's having already compensated heart failure with stage 2 CKD. So these two important points, along with the elderly patient, you have to decide what therapy will work. Here the sulfonylurea may not work, but the duration of diabetes is 12 years with a A1C of 8.6, and this patient is already on triple drug. Sorry. So this patient will definitely require insulin, but that insulin should not cause a hypoglycemia. That's a major concern for us. So along with
One limit left.
maybe SGLT2. Yes, the last. It will not be more than 1 minute. I'm not going to take more time. So the insulin along with SGLT2 will be the added for this particular patient with 8.6. And a similar way. So this is how the RSSDA guideline can help our patients to decide the therapy, or for any patients. I'm just giving you one more example with a patient who is a female 60-year-old with BMI of 26. Again, EGFR is slightly low with inferior wall MI. So I mean, you have to decide which are the 2 and 3 factors which are very important, and what therapy is already on, and patient is how much the duration of diabetes. To conclude my talk, the RSSDA ESI therapeutic guideline, which we have created since last 5 years, helping our doctors and patients across the country. And this year, we have come out with the unique idea of getting the district coordinator, and all across the country, more than 700 district coordinators we have involved for this RSSDA ESI guideline. We have already conducted more than 500 online CME for all these districts. So to conclude my talk, management of type 2 diabetes has substantial effect on individual and societal health, psychological well-being and quality of life, as well as economical repercussions. Diabetic management planning should be individualized, not one-size-fits-all treatment patterns for diabetes with diabetic patients, and individualized therapy could serve as a real-world approach. With this, I thanks Dr. Mahapatra and Dr. Manoria for giving me an opportunity. Thank you.